In this diagram, we see some variations in pulmonary artery development and pulmonary atresia. Note that the pulmonary trunk appears disconnected from the right ventricle, although anatomically we may see a small hypoplastic pulmonary trunk. Occasionally, the right and left primary divisions of the pulmonary trunk are also involved, and the only pulmonary arterial tree is seen within the lung itself. So all these are variants that show the spectrum of congenital heart disease that varies from pseudotronchus arteriosus to true truncus arteriosus to complete agenesis of the pulmonary arterial tree. And then the only blood supply would be via systemic arteries, particularly the bronchomediastinal arteries. In patients who have congenital absence of the pulmonary valve, one feature that is observed on standard chest rentgenograms is the markedly enlarged proximal pulmonary arteries. As infants have a small airway which are easily compressible because of the softness of the cartilaginous structure, it is possible to observe a ball valve mechanism. In other words, air can go into lobes but that cannot get out during expiration due to the compression of the pulmonary arteries on the airway. And in this case, we see air trapping in the right middle lobe and left upper lobe from massively enlarged pulmonary arteries. The angiogram of this patient shows the markedly enlarged proximal pulmonary arteries and explains the air trapping phenomena of the right middle lobe and left upper. In agenesis of the pulmonary artery, when it occurs on the right side, it may appear as an isolated anomaly. On the other hand, agenesis of the left pulmonary artery is often a variant of the tetralogy of Fallot. In tetralogy of Fallot, we see infundibular pulmonary stenosis, and often there are abnormalities in the connection of the left pulmonary artery with the hypoplastic pulmonary trunk. This is a patient who was completely asymptomatic. Note the large left lung, the small right lung, and the small right lung has a decreased vascularity. The mediastinum appears shifted to the right. Are we dealing with air trapping on the left side, or are we dealing with a primary vascular insufficiency of the right lung? Clinically, the patient was asymptomatic. A selective pulmonary arteriogram revealed absence of the right pulmonary artery. We see a normally perfused left lung. Rather than doing a pulmonary angiogram, a perfusion scan would have sufficed, and fluoroscopy would have shown that there is no evidence of air trapping. That is, we would have seen a synchronous movement of the two domes of the diaphragm. A bronchographic examination revealed a small right lung and no evidence of central bronchial disease. Note also hyperexpansion of the left lung. So this study ruled out the possibility of a central obstruction of the right bronchial tree, also ruled out the possibility of bronchiectasis, and suggested a congenital origin for the small right lung and the hyperlucency of the left. The latter would be the result of hyperexpansion as a compensatory phenomenon. In pulmonary atresias, the lungs become oligemic, and this is such an example of a baby with pulmonary atresia. Note that the two lungs are markedly hypovascular. These are two other examples of congenital absence of the right pulmonary artery. Note that the vessels appear somewhat feathery, and this should be indicative that the collateral circulation is at the expense primarily of the bronch. Note in this close-up of the right lung the feathery appearance of the intrapulmonary vessels, a hypovascular right lung, and the absence of a normal right hilus. In other words, we do not have a right pulmonary artery in the right